Assalamu alaikum. This is Dr. Resham, Associate Professor in Gynae Ops Department PUMS. And today this is a lecture, second one in the series of a lecture which I have started. The first one was on the GTD. Now today's topic of discussion is pelvic inflammatory disease. What we are going to study today, this is objectives. Okay, and today's objectives include definitions, burden and impact of a PID, risk factors, clinical presentation, organisms involved in a PID, what are the differential diagnosis for the PID, how to diagnose PID, how to manage PID, how to follow up, and in the last conclusion. So what is the definition of the PID? PID, the pelvic inflammatory disease. It is the inflammation of the upper genital tract, starting from endometrium and onward. Here we can see the lower genital tract and the upper genital tract both in this figure. Up to cervix from the vagina is included in lower genital tract. From this body of the uterus included in the upper genital tract, also includes tubes, even the ovaries. The inflammation of the fallopian tube, that is salpingitis, included in the PID, ovary, oophorytis, also in PID, the endometritis, myometrium, metritis, serosa, serositis. These all are constituting the PID. If the whole layers of the uterus are involved, infected, inflamed, this is termed as parametritis. Not only up to uterus, but even the infection of the PID can spread outside the uterus, giving rise tubo-ovarian mass even, giving rise peritonitis even, pelvic cellulitis even. So whatever the component of this genital tract, upper genital tract involved, this constitute the PID. So moves forward. Now the burden and impact of the disease. You know, in developed countries, it is suggested that about 2% of young women in the UK gives a history of PID, and about 1 in 50 consultation made by the young woman with general practitioner related to PID. In developing countries just like Pakistan, to dig out the prevalence is very difficult. However, some studies even suggest the prevalence of PID up to 27%. And the most common cause here is the chlamydia and the gonorrhea. The burden of disease, impact of disease sometimes is very serious, can lead to even infertility, tubal damage, chronic pelvic pain, ectopic pregnancy. Also having some psychological influence on the patient, affecting the psychological quality of life. Not only psychological, but also affecting the financially, because women has to spend a lot of amount on treating the PID, on visiting the doctor. So it is not without risk. Who are the patients at the risk of PID? These are the patients who are having behavior and socioeconomic factors, who are smokers, who belongs to lower socioeconomic status, who are living in unhygienic conditions, who are having poor education of the health, who are having low education about the sexual activity, who are malnourished persons. These all are at the risk of the PID. And those persons who are at the risk of STI are also at the risk of the PID. And these are the couples less than 25 years of the age, the women having multiple sexual partners, or even the polygamy is very prevalent in Pakistan, and the couples who are practicing the unprotected sexual intercourse without the utilization of the barriers, who practice bridging effects, or having history of prior PID. What is the association of the Bacterial vaginosis with the PID. Some studies suggest that vaginosis leads to PID, but most of the studies suggest that there is a synergistic effect between the both of these conditions. Bacterial vaginosis, that is defined as the overgrowth of the normal commensal bacteria in the vagina and the loss of vaginal lactobacilli. Whenever the patient is having vaginosis, these patients are also giving history of PID and the vice versa. What are the organisms involved in the PID? Chlamydia. First of all, it should be remembered that the PID is a polymicrobial infection. Not only a single organism is constituting the PID, a lot of organisms found together. But the most common one is the Chlamydia and Neisseria gonorrhoeae. First of all, we will discuss the Neisseria. Neisseria constituting the 5% responsible for the 5% of the PID patients. In 50% of the patient, this is asymptomatic. This is a gram-negative diplococci found in the pairs of red kidney shaped on microscope, and they are found within the polymorph, right? And Chlamydia trachomatis, this is the most common organism responsible for the PID, present in 30% of the patient with the PID. It is asymptomatic in 2/3 of the cases, right? It is the obligate intracellular. So whenever we are going to diagnose or we are going to take samples, swabs for this Chlamydia trachomatis, we have to rub the cervix or rub the vulva vagina, whatever, from where we are going to take the samples. Mycoplasma genitalium. This is having a great role in the tubal factor infertility. Though the testing for the Mycoplasma genitalium is very expensive and it's not routinely available. Anaerobes. Anaerobe bacteria are of particular importance in a woman with a severe PID. However, its role in mild to moderate, it is not very clear. The organism involved are bacteroides, peptostreptococci, and the peptococci, and much more. They are as isolated from the patient with a severe PID because of production of the mucinase and salidase to facilitate the invasion of the other bacteria even. Then is the actinomyces. It is very much specific in a patient who are using the IUCDs, intrauterine contraceptive device. Though the most common organisms in patient with the intrauterine contraceptive device are the same polymicrobial, but the actinomyces, if it is present, usually associated with the intrauterine contraceptive device. Whenever patient present with history of IUCD insertion and the infection, we have to remove if not treated with the antibiotic or refractory to treat it with the antibiotics. Then the Mycobacterium tuberculosis. As we all know, this is very common in developing countries just like Pakistan. Though the pelvic infection usually occurs secondary to the hematogenous spread from the extragenital source, but occasionally Mycobacterium tuberculosis can be transmitted sexually. So many viruses are also involved in PID, not only bacteria, and these include herpes simplex, Coxsackie, respiratory syncytial virus. So these were the organisms responsible for the pelvic inflammatory disease. So let's move forward. Now, how the patient with the pelvic inflammatory diseases presents to us. These patients having most common symptoms are fever, along with nausea and vomiting, generalized body ache, along with lower abdominal pain, along with dyspareunia, dysmenorrhea, a lot of patients present with vaginal discharge, which are usually with smelly, and if the endometrium is involved, which is more common in most of the cases, patient may present with the heavy menstrual bleeding or abnormal uterine bleeding. What are the signs in a patient who present with the pelvic inflammatory disease? Whenever we examining the patient patient is usually having the high grade fever or even sometimes low grade fever when, for example, in case of the mycobacterium tuberculosis, right? Patient may have a abnormal vaginal discharge on examination when we are doing the perispeculum examination of the patient. When we are doing the bimanual pelvic examination, patient usually shows the cervical tenderness, cervical excitation, or cervical motion tenderness, we can say. On moving the cervix, patient show tenderness. When we move the uterus, patient show tenderness, that is uterine tenderness. When we move the adnexia, the patient show the tenderness, that is adnexal tenderness, and these tenderness are very much specific to the pelvic inflammatory disease. Patient sometimes present with the right upper quadrant pain, and right upper quadrant is also tender on examination. Here is the picture which shows the adherence in between the undersurface of the diaphragm and the liver. That actually this is a laparoscopic finding showing the Fitzhugh-Curtis syndrome. Whenever inflammation is so much high, spreaded outside the genital tract and involving the undersurface of the diaphragm along with the liver, so it is termed as Fitzhugh-Curtis syndrome, and patient usually present with right upper quadrant pain and which is tender as well on examination. How to investigate a patient with the pelvic inflammatory disease? I used to tell you regarding investigation. In every patient, we should advise baseline investigation to see the general health profile of the patient and the certain specific investigation, right? In baseline investigation for the general health profile, these investigations are complete blood count, blood group, viral markers, random blood sugar, and urine. CBC may show the raised total leukocyte count, may show the raised ESR, and may show the raised C-reactive protein. These three are the inflammatory markers, but though these are the non-specific to PID, they only suggest that somewhere inflammations happen in the body. That is TLC, ESR, and C-reactive protein, right? And certain investigations should be advised in such patient. For example, serum beta HCG, as patient usually present in reproductive age group, so and usually present with the abnormal uterine bleeding. So first of all, the pregnancy and pregnancy related complication should be excluded. Then let's discuss some imaging. Ultrasound, whether transvaginal or transabdominal, the better is to have a transvaginal. Whenever we are assessing any pathology in the pelvis, we should advise the transvaginal ultrasound. Ultrasound may be show abnormal finding if the complications of the PID are present. For example, either advanced disease suggesting a fluid in the endometrial cavity, a fluid in the pouch of Douglas, or the tubo-ovarian abscesses, collection of pus, presence of pockets inside the peritoneal cavity. So, if ultrasound is inconclusive, we can even offer the patient regarding CT scan and the MRI. Then there is the role of laparoscopy. You know, whenever we are taking the swabs from the fallopian ends, that is infundibular end of the fallopian tube, these are very much specific to the and confirmatory to the pelvic inflammatory disease. But though considering it as an invasive procedure, though minimally invasive, but it is invasive, so we are not advising in every patient. The diagnosis is usually made clinically, but whenever we have a chance to do laparoscopy by other condition as well, and we are seeing the formation of pus around the fallopian tubes or in the peritoneum around the ovary, we should have a swabs from that site for the isolating the organism for the culture of that organism. Then high vaginal swab and endocervical swabs should be taken in these patients and this should be sent for the culture and sensitivity and other specific investigation for the particular organism. These are the findings which are we usually seen in the laparoscopy. This is clear-cut picture showing the hydrosalping. The whole tube, look how beautifully show the presence of fluid inside the fallopian tubes. This is termed as the hydrosalpings. And here the multiple adhesions are formed and this tube is so much engorged that become hematosalpings, right? And these are the adhesions in between the uterus and the undersurface of the peritoneum, and these are fine to gross adhesions, right? These are also a complication of the pelvic inflammatory disease. These are the picture showing the gross examination of the cervix, showing the pus, presence of pus. These are the gadget from which we are taking the sample of the pus, and these are the microscopic presentation of the organism. How to diagnose the pelvic inflammatory disease? I have discussed multiple symptoms, multiple signs in a history. I have discussed the clinical examination with you. I have discussed the investigation. Though we can't advise the whole range of investigation, but it should be individualized basis. But there are certain essential features through which we are diagnosing the pelvic inflammatory disease. And to be honest, this is wholly solely a clinical diagnosis. We can't wait a lot of investigation to come. We usually start the empirical therapy in case of the pelvic inflammatory disease whenever we are suspecting this PID on clinical grounds. Though the essential features which constitute the PID most likely are cervical motion tenderness, which I discussed with you, adnexal tenderness, and lower abdominal pain, which is usually bilateral. Though the supporting features, along with, in addition to the essential features, are intermenstrual bleeding, postcoital bleeding. Usually, when cervix is also involved, this shows the postcoital bleeding, and in most of the cases, the organism usually ascends from lower genital tract towards the upper genital tract. So there is a sign and symptom also from the lower genital tract infection as well, just as postcoital bleeding, vaginal discharge. There is deep dyspareunia to the patient as well. Patient may show the fever, nausea, vomiting, right upper quadrant pain, and generalized peritonitis if the infection is very much advanced. What are the differential diagnoses? When our patient present to us with a sign and symptom suggestive of pelvic inflammatory disease, there are a list of differential diagnoses which should be excluded first. For example, ectopic pregnancy, right? The patient with ectopic pregnancy, the significant features are, of course, the menstrual history. There will be an amenorrhea. Initially, there will be a unilateral pain, and serum beta HCG or the urine pregnancy test will be positive, right? And there are signs and symptoms also suggestive of the pregnancy, and there was severe pain, right? Second, ovarian cyst rupture or the torsion. Though initially there is a unilateral pain and often mid-cycle pain. Furthermore, the ultrasound and the further investigation or laparoscopy can differentiate. Inflammatory irritable bowel syndrome, either central or left-sided pain, and there is no cervical excitation. Inflammatory bowel disease, either central colicky or left-sided abdominal pain, and there are also a lot of bowel symptoms. Urinary tract infections, usually there are the urinary symptoms, that is frequency, dysuria, burning micturition, with or without loin pain. Then the bowel torsion, here there is a usually central pain and patient usually having a signs and symptoms suggestive of bowel torsion, for example, nausea, vomiting, absolute constipation, abdominal distension, and in last, psychosomatic pain. Usually inconsistent symptoms are there. Now, how to manage the patient with the pelvic inflammatory disease. In management, there are general measures. and the certain specific measures. General measures, whatever the patient having symptoms, we should treat these symptoms. If she's having vomiting, antiemetic given, pain, antispasmodic or painkiller should be given, right? If fever, antipyretics should be given. If cough, antitussive should be given, right? And a little bit advice for the bed is improving hygiene and improving diet of the patient, right? And should be educated regarding the safe sexual practices, right? Among specific measures, first of all, there is an antibiotic cover. There are certain regimes which are maybe outpatient department regime or maybe inpatient department regime. We'll discuss later on. And the second component is the management in specific measures. There's a contact tracing or treatment. Whatever the contact in a patient within 6 months, we should be tracing that these persons and should be treated. This is usually in the developed countries where these practices are very common, but in Pakistan, we should treat the partner must. There should be abstinence of the coitus for at least 2 weeks. And after that, the safe sexual practices should be practiced. Lifestyle modification, I have already told, is if she is smoker, please quit the smoking and alcohol and whatever the drugs she is using for the sexual purposes, whatever she should avoid these. And very common and very significant is that we should screen the other STIs, because the patient with the STI are at the risk of PID and the patient with the PID at the risk of STI. So we should screen the other STIs, right? What are the antimicrobial therapy? There are 3 regimes in outpatient department regimes, and these are including ofloxacin 400 milligram twice a day, or metronidazole 400 milligram twice a day. Second regime is only utilization of moxifloxacin 400 milligram a day, once a day, right? Third is initially injection ceftriaxone 500 milligram IM is given, followed by the doxycycline 100 milligram twice a day and metronidazole 400 milligram twice a day. Whatever the regime is chosen out of these 3 should continue for the 14 days. Should continue for the 14 days. Okay, now the antibiotic therapy, which are usually advised parental. Though we are usually advising the oral treatment, but if patient is not responsive to the oral treatment or not tolerating the oral treatment or having a severe disease suggestive from certain findings, or having signs of the pelvic peritonitis or the tubo-ovarian abscess, patient should be hospitalized and should be offered the parental antibiotic therapy, right? And these regimes usually are most common 3. And first is that initially offering the intravenous ceftriaxone 2 gram along with doxycycline intravenous, metronidazole intravenous till the patient becomes symptom free, followed by the doxycycline and metronidazole I have discussed as previously. Both of these regimes should have a duration of 14 days in combination, right? Initially injectable and followed by the oral, right? Initially injectable ceftriaxone, doxycycline, and metronidazole, followed by the doxycycline and metronidazole oral form when patient becomes symptom free, but the duration should be 14 days. Second regime include the clindamycin, intravenous, and gentamicin. Gentamicin given in initially loading dose and then followed by the maintenance dose. But initially these both are given in injectable form, and once patient stable, followed by the doxycycline and metronidazole I have previously described. The combination should up to the 14 days, right? Then third is the ofloxacin and the metronidazole injectable form, followed by the ofloxacin and metronidazole when patient become symptom free. So these are the parental, either of them can be chosen as a parental antibiotic therapy, right? Now, is there any role of the surgery for the pelvic inflammatory disease? Though Not very much useful, but unless patient, if patient having complicated or there's a formation of the pus or tubercle abscess, for example, there are a lot of adhesions are formed after the pelvic inflammatory disease, then there is a role of surgery. If small abscess is there, the transvaginally can be drained. But if the larger one, then the laparoscopy or laparotomy is needed, whatever the facilities available, whatever the indication established, right? So, and if in tubercular abscess, if patient is very young and needs conservation of the ovary, and then it should be drained. And if it is having the necrotic or ischemic changes in the ovary, and patient is not in favor of the preserving fertility, they should be removed, right? How to follow up? During the treatment, initially, the follow-up should be done at the 72 hours to see the response. If there is a no response from the oral treatment, either parental is started, or if there are no treatment even on the parental, then further investigation is required to exclude the other differentials, right? Or we can consider even the surgical intervention in case of the abscesses or the adhesions are there. Second follow-up at the 2 to 4 weeks after the antibiotic therapy. Again, to see clinical response, and here's the time to screen and contact sexual partner and offer treatment. Even we can offer the repeat testing for the gonorrhea chlamydia if the persistence and symptoms are there. So follow up at the two level, at the 72 hours of the start of treatment and at the 2 to 4 weeks of the start of the treatment, right? A test of cure. This is for the Neisseria and the gonorrhea both, right? And for the mycoplasma after 4 weeks of the start of treatment. Now we are at just to conclude. Initially, for the conclusion, that though the PID is very preventable, right, and should be prevented at any cost, right? As the chlamydia is the most common organism for the pelvic inflammatory disease, and in two-thirds of the patient it is asymptomatic. So here is a significant role for the chlamydia screening program, though it is should be screened in the young population, and whenever screened, it should be treated with the doxycycline or the azithromycin to prevent the formation of the pelvic inflammatory disease and its sequelae, not only the young population, but in those patients who require some kind of intervention, instrumentation in their genital tract. So these patients should be offered screening for the chlamydia, and whenever they are screened positive, should be treated along with their partner. But for example, if we are offering the screening test and they are not willing for the screening test, then simply the treatment should be offered to them. Now, what kind of contraception, right? But before that, I should complete this conclusion slide that early diagnosis and treatment can save the sequelae, we all know, right? Contact tracing is very mandatory. Now, what is the role of contraception? What contraception can have an effect on the pelvic inflammatory disease? Some studies suggest that OCP reduces the PID. Some studies suggest that OCP, oral contraceptive pills, enhance the pelvic inflammatory disease. But in fact, the PID and contraceptive have a relationship with each other. How? Contraceptive, we all know the steroids, and steroids an immunosuppressive. Though the study suggests it reduces the incidence, yes, because the steroids initially suppress the infection, so patient may have show the improvedness. But this is a steroid; it is just suppresses the infection, not eradicating the infection. Later on, it can enhance. So this is a relationship between the pelvic inflammatory disease and the contraception. And for intrauterine contraceptive device, we have studied that actinomyces is specific to the IUCD users, but actually whenever we know the intrauterine contraceptive device is inserted, the most common organism is the polymicrobial, though the Actinomyces is specific to IUCD, but IUCD users usually having the polymicrobial infections. But this is not the IUCD which is causing the infection. This is the technique, how it is transmitted, or how it is inserted. IUCD how inserted, in what condition, in what environment, whether hygienic or unhygienic, whether the sterilization have been done or not, or aseptic measures are taken or not. These are responsible for the infection introduction at the time of IUCD insertion. So this was all about the pelvic inflammatory disease. If students, or if any one of you having any query, any question, you can ask me in the WhatsApp group. Inshallah, soon I will deliver the third lecture of my lecture series. Thanks a lot. Thank you.